assessment, but many of us find difficult to implement it. And in reality, in majority of the hospital in our country, we do not implement it. So Professor Wantanee's insightful practical lecture will definitely motivate dietitians and nutritionists to carry out this very important task and help in the overall management and the better outcome of the patients. It gives me an immense pleasure to welcome James Eiberger. I think I rightly pronounced his name, certified nutritionist and fitness coach, Football Association of Singapore. We are very happy to have you among us. Nutrition and the role of dietitian or nutritionist in sports is often neglected, and we cannot deny the fact that better nutrition will definitely enhance the performance of a sports person. Your lecture on nutrition in sports, your experiences and challenges you faced will be an eye-opening for all of us and a new field to practice for the dietitians. This is the pride moment for me to welcome all the participants from, I think, today we have participants from different countries also. So we welcome all of you for today's international webinar. I hope many of you will benefit from today's sessions. Before we start the session, let me give you an overview of Nepal Dietitian Association. As you may be knowing that Nepal Dietitian Association was established in 2010, 15 Jan 2010, with the initiative of 8 dietitians working in different hospitals of Kathmandu. It's a registered under District Development Committee and District Administration Office. It is a non-profitable organization. And this association is working for the dietitians and nutritionists to safeguard them for their rights and welfare according to the country's laws. We are advocating for the provision of dietitian and ratio of the number of beds in different hospitals as amended by the health regulation of the government of Nepal. We always try to involve dietitians and nutritionists working in various hospitals and organizations for the reduction, prevention, and management of rapidly growing number of non-communicable disease and malnutrition in the country. So far, we have organized capacity building trainings for dietitians, regularly organizing exhibition cum awareness programs for the general public on different issues in hospitals and communities. We are conducting regular CNEs and webinars like this to the professional dietitians and students on various topics to update and empower them. We hope similar collaborative programs can be carried out in the future with Mahidol University, and I think Mr. James can be an asset for us, for all the dietitians, if they want to have a future in sports nutrition. Now I request Ms. Moe, moderator for today and coordinator of this whole program, to proceed for the session. I would like to especially thank you for all your efforts. Without you, this webinar would not be possible. I would like to welcome all of you once again, and over to you, Ms. Moe, and you can start. We can now go start with the presentation of Professor Wantanee. Thank you very much.
Yeah, great. Thank you, Madam Shakya, for this wonderful welcome speech. And I'd like to introduce Dr. Wantanee Kriengsinyos. Dr. Wantanee Kriengsinyos, PhD, is Associate Professor at Institute of Nutrition, Mahidol University. Dr. Wantanee Kriengsinyos has 20 years of professional experience in clinical nutrition and dietetics. Our current research involves metabolic studies of food products in development of non-communicable diseases, NCDs, body composition, and energy expenditure, diet and behavior modification of patients with diet-related chronic diseases, and protein quality and amino acid metabolism. Over the past 5 years, Dr. Kriengsinyos has also developed experience in nutrition policy and was a part of the team that successfully worked to ban partially hydrogenated oils in Thailand. She currently leads a promotion project on implementation of healthier food logos to combat NCDs through reduction of sugar, fat, and sodium consumption in a Thai population. Currently, Dr. Kriengsinyos is the chair of the Master of Science in Nutrition and Dietetics program at the Institute of Nutrition, Mahidol University. She received a doctorate in nutritional sciences at the University of Toronto, Canada, and holds a registered dietitian credential from the United States. We are very honored to have you here with us, and without further ado, Dr. Kriengsinyos, the floor is yours.
Thank you very much for your nice introduction. So I also have to thank you, the Nepal Dietitian Association, that invite me to join, and to share my experience related with the nutrition screening and assessment, So then we will take some time, in order to talk on this, I will share my screen, okay? Okay, so I think that in this morning, we probably sharing on the nutrition screening and assessment a challenge. As you know that, one of our job, as a dietitian, we have to do some kind of the nutrition intervention, is right, in order to make the, the patients get better. So let's say that, why do we, perform the nutrition screening and nutrition assessment in clinical setting? So I think that, in the thing that, I'm not quite sure that in each country may have a different stage to be the dietitian, registered dietitian, or dietitian, registered dietitian nutritionist in some country called like that, as mentioned that it's just the topic of the today, it might be, wrong. I mean, for the details, if we go in really in depth on the methodology of the screening and the assessment, it might not have the enough time. But anyway, for the overview and discussion on this, I think it will be okay. So why do we perform it? So I think that probably everyone know that, in that step that normally have nutrition screening, in order to find, the people that may to be at least is right, to may have the problem on the malnutrition. When we say about actually the word of the malnutrition can cover both the overnutrition and undernutrition. However, when we talk in the clinical setting, in the past or until now, the problem on the undernutrition is something that, if they have, to be take care of it, to be aware of it, and to provide a good nutrition intervention, it would be get the people or the patient is much, feeling better, or everything is much better, is right. So I think that would be the main important thing. That I show you that I'm not quite sure that how much of the undernutrition in the hospital in the Nepal, but overall, as the information that we got it, undernutrition is the hospital is actually is not uncommon. It's pretty common, is right. In the British study, allow 46% of the general medicine patients, have the undernutrition. In the USA, allow 31%. How about in Thai? Actually, in one of our hospital, mainly we know is Ramatipadi Hospital. The doctor nutrition over there, get the information is allowed 40%. So I believe that in your country, approximately around the same. Therefore, if we can recognize on this one and provide the better nutrition, it will be good, is right. It's just that, we know that early diagnosis, early to find out and provide anything, it get a better outcome. Is it true? So early identification of the high-risk patients, is the study, it will be, differently allowed that. But you can see that, the intervention that will decrease and also decrease the mortality rate by, allow 50%. Early nutrition support at the Ramatipadi Hospital that I show you, the length of the stay will be decreased, as you can see in here, is right. If it's early, the length of on the first day, the length of the stay is only 7 days, and the rest is between 4 to 19 days. However, if we have provide the rate of nutrition support, it, it's almost 3 times that the people have to stay in the hospital. So I think that would show the important thing of the nutrition screening and the nutrition assessment. Okay. Sorry. then I think that we probably familiar with, this circle is right as a nutrition care process. As you know that we have the nutrition assessment, and you can see in here that the assessment in order to get a nutrition diagnosis. It's just if we do not assess, we may not provide the nutrition diagnosis properly, which is not the same with the medical diagnosis, is right. And then we can provide the intervention and maybe work as a, healthcare health professional team in order to provide the nutrition intervention and also the evaluation. But for today, we probably emphasize on the screening and the assessment. So what is the screening? It's the first right process of identifying, is right, that the people that is maybe already malnourished or at least of becoming malnourished. I think that would be the thing. So it should be the first, and who would do it, so we can discuss it, is right. And then we may go further to more in depth to do the nutrition assessment, which is the evaluation of the nutrition needs of the individual, is right, based on many of the information such as the biochemical, anthropometric, physical, and dietary data, in order to determine the nutrient needs, recommend an appropriate of the nutrition intake, which can be either enteral, parenteral nutrition or whatever to make the patient eat better, is right. So now we come up to say that what is it, to do the screening, which is, we will in the first part that we may talk to about the nutrition screening, and then we step to more in some of the nutrition assessment. Okay, then when we do the screening, what we have to do, we discuss more, such as the intake, whether they increase the needs or whether the others on that things. So we want to find that whether the patient have the malnutrition or risk of malnutrition. If it's no, so we don't have to do anything at this moment, is right. It might be do this screening, and how often to do screening, that would be another story, is right. However, if we find that person, yes, risk of malnutrition, what we should do, we just leave it. So I think that this is really important, that what you call the policy of the hospital have to be aware and agree to do this. Otherwise, only our professional, we may not do anything, because you also need to coordinate it with others, is right. Suppose it's yes, then the further assessment, it calls just the screening, it might not know, we know just is out at least, but we may not know what we have to do to intervention, is right. Therefore, in order to get the nutrition diagnosis properly, the good assessment have to be done, is right. So nutrition status, nutrition deficits, or what is the underlying causes, whatever, how could we make the people eat more? Suppose that they eat less, is right. So what's of the thing on this thing? So when we do the assessment, whether the assessment get the same results that people that at least of the malnutrition or not, we suppose it's right, because we spend a lot of time to do more on the assessment. Yes, if yes, so we have to do intervention. However, maybe it's no, depend on many of the reasons on that. Then if assessment is no, so they may have to be re-screening next time or something like that, So when we come up that, when we get, then I think today we won't go on the intervention in the goal on the nutrition care process, right? But the concept just to make the people to get better of the nutrition status, and then evaluation, I think, on this one. Okay, just in the brief in the beginning, what is different between nutrition screening and assessment? Are there any idea? So as we know that the assessment, you may know that lots of the step in the detail, therefore it takes our time to do it. So I think it's also how many dietitians in a hospital. I'm not quite sure in that one, is right. For some support in Thailand, we may have only 2 dietitians, in some hospital, have very limited of the dietitians. and how many beds of the patients in the hospital. Do we able to do everything? So this is right. Then that would be the something is right. And in the beginning, the goal or the objective that we want for the patient at least, and would be get the benefit for the intervention in order to get a better of the outcome, something like that, length of the stay on the hospital lower or whatever. I think in the beginning, we can see that the screening, it should be simple and easy, is right. Should be the minimum of the measurement, and it might be some of the routine data, on this one, and cost effective, concise information, reliable, effective, and valid identifying of the nutrition problem, and can be facilitated by any member of the healthcare team. In many of the hospitals in Thailand, it might not be the dietitian to do it. It can be the nurse or some kind of the clerk or something like that. Or how could we use some kind of the technology to help us? I think that would be the issue that we, many hospitals want to do some kind of that. Then we can less the minimum, and then we can go further for the next step, right? How about for the assessment? As I mentioned, that many steps, many of the information, it takes longer time. More measurement, we may have to ask more in many things, right? In terms of the cost effective, you take more time, it's more expensive. In-depth information, again, it has to be reliable, effective, and valid in order to go on the nutrition diagnosis. If we can, get the right of the nutrition diagnosis, then the intervention will go more appropriate and more effective, is right. And it might require more experience, and normally it have to be done by our clinical dietitian, is right. So what is the challenge? I think that we can discuss more that, what information that we really need it. How long time to complete? Is it difficult? All the patients that come in the first time, do everyone have to do it? Is right. If you have, more than 500 beds, suppose that is for the inpatient. And how about the outpatient? What should we do? I think that would be something that, so I think it's also depend on the policy of the hospital. Okay, let me go a little bit more in detail on the nutrition screening too. So I just, quoted from that the Joint Commission, which is from the, Academy of Nutrition and Dietetics. Nutrition risk identified in hospital patients normally should be within 24 hours of the admission, but that's not a method of the screening, so they not really say that what method it should be good, I think that would be the thing, whether we can do it, I think that would be. And then what the screening tool, I think I just review and provide you some of the information which I believe that you guys may already know on this one. This common of the screening tool that use is, have the malnutrition screening tool, MST, malnutrition universal screening tool, MUST, nutrition risk screening, NIS2002. And I just want to introduce a bit, or show you on some of the Thai. Actually, we also may adopt it from some kind of the, the one that I already mentioned. We call the SPEN nutrition screening tool. SPEN is stand for the Society Parenteral Enteral Nutrition in Thailand. So I think that it can be, in the past, we also have a different, however, when we talk or want to discuss and to compare, we might not be able to compare or discuss. Then, it's just because we have the, the association, as the parenteral enteral nutrition in Thailand. That's why they try to make it more uniformly on this one. So the first thing I just show you about the MST. The MST just have this one, for the screening, multi-testing tool. They just ask that, has the resident or patient lost weight recently without trying? No, unsure, or yes. And for the yes, is how much of the weight loss. So they just ask on that thing. So basically just one on this one. And you can see the scoring will be from the, score from 0 to 5, on this one. And then the 5 is just total score is only 5, is right? Because they have only 2 questions. One question is on the weight loss. The second question is has the resident or patient been eating poorly because of a decreased appetite? Yes or no? So you can see that just only 2 questions about how they eat less or not, appetite and the weight loss. And with the weight loss can be scored from the 1, 2, 3, or 4. If it's unsure, providing 2. And if the score is less than 2, it's okay, no problem. What is more than or equal to 2 is at least of malnutrition. So this would be something very easy from the MST. Okay. How about the next one? The next one they call the Monetization Universal Screening Tool, or MUST. MUST is a useful tool for the rapid estimate of the grade of undernutrition. Is that, some of the disadvantage is the recent food intake is not included, and calculation of the percent or something like that. So let's look on the MUST, So the MUST, they have this one. If you remember MST, just ask about the weight loss and how about the poor intake is right. For the MUST, they have the BMI score, which is this one, depending on the score. More than 20, or more than 30 is obese, get 0, normal or less than. So you can see that the scoring, it would be the, too much score, the same that has a problem is right, higher score. Weight loss score, 5%, 10%, and, and more than 10% is right. And the step T is the acute disease effect score. If patient is actually ill and there has been or is likely to be or to be no nutritional intake more than 5 days, and then come to the overall of the list of malnutrition. And then they have some of the information in here that if unable to obtain weight, height, so looking on the alternative measurement and use of the subjective criteria. So that would be something that is a challenge. If you get some of the patient come and without the weight, how could we know the weight is right? And for the height, so how to determine it and how could we go on the weight loss? So I think this would be something is also a challenge. If we get the, acute patient or something and there's no history data on this one, and the acute disease will also, if it's unlikely to apply outside the hospital, so in that one. So they add the score together. If the 0 is low risk, if it got 1, it's medium risk. And if they get score or more, it will be the high risk on this one. So it would be another that it mainly from the, I think from the Marpen group on this one that they use it. So, and add the score, as I mentioned that, on this one, the same as in that one, 0 is right. It's routine clinical care for 1 observed and for more than or equal to 2, give some the treatment, which is just referred to the dietitian, nutrition support team, or implementation local policy to improve, overall of the nutrition intake, so it's depend on. So that would be the implementation. And in that one, they use, either in the community or in the clinical also by using this one. Okay, that would be 2 of that common that people use, MST and MUST. How about the next one? The next one we call the, from the SBEN, in this one, they have the nutrition risk screening or NIS, start in 2002, so on that one. The NIS 2002 that, start with the question about 4 items, this above for an initial screening. If any of the question is answered yes, then, so we're looking on the detail on this one. So what is 4 question? Is BMI less than 20.5? Yes or no? Has the patient lost weight within the last 3 months? Yes or no? Has the patient had a reduced dietary intake in the last week? And is the patient severely ill in the intensive therapy? Yes or no? So if the answer is yes to any question, that screening in step 2, they may perform. And if the answer is no to all questions, the patient is re-screened at weekly interval. If the patient scheduled for a major operation or the preventive nutritional care plan is considered to try to avoid the associate list. So they can do it, on this one, So, so in this case, we already mentioned that on this one is right. So this would be from the S-pen on this one. To do more that you mean in this, on this one. So you can see that nutritionist screening for final screening, if equals 0, 1, 2, 3, or some kind of that, they provide you some kind of the severity of the disease that they provide the scoring or something, they provide you information, is right. So this would be something that as a screening, people do it, in the hospital. Okay, I think it's the same concept, is right. Sorry that maybe some is in Thai. I mentioned to you, it's a spend nutrition screening too. So you can see that we use around the same from the S-pen, is right. So, but, we have 4 questions, but we may make it more, what we call more relate and reliable in our Thai population, Thai patients, have us, to do with the validation on this one. And we find out that, the 4 questions that is reliable, it is valid in our country. So what is the 4 questions? So the first one is unintentional weight loss within 6 months. So if they don't want to lose weight, but they have a weight loss, unintentional in the past 6 months. So with the same, the answer will be yes or no. You can hear that. So we can ask it, the form that, we can use in the outpatient, on this one also, and to see out. And then the second one is how about to decrease the food intake more than 7 days. In the past 7 days, if they can eat less, they cannot eat the normal or whatever on that thing. So we ask them in the past week, so it's decrease of the food intake. And for the BMI, we're looking both the BMI lower than 18.5 or is more than 25, which is in the Asian classification that Thailand used, that the BMI more than 25, we classify as obesity, And the last one, do the critical illness or semi-critical illness, on that one. So the same thing that if the answer is yes, more than 2 questions or equal to questions, started from 2 questions, we should do conduct nutrition assessment or consult nutrition support team or dietitian, So if it's, less than that, from 0 or 1, we may screening every week if they are in the hospital. So if you're not in the hospital, it's right for the outpatient. So it's okay. Then for maybe the next visit, we can do that for the screening. It's right. So will be the routine of the screening, something like that in some of the hospital in Thailand. I did not say that all the hospital, to list to screening like this, but mostly. Okay. I just want to, let you to think about it, If you have 3 patients, 3 people come to see you in the, or maybe you are in the outpatient, clinic, is right. And then have 3 people. And these 3 people, do you think that these 3 persons have any problems? Do you have to do anything with this person? Based on the screening tool that you heard it, maybe a few minutes ago on this thing. Mr. A, Mr. B, or Mr. C. What do you think? What would you do to do with these 3 patients? What do you think? What do you think? What we're supposed to do?
Yeah, hi, good morning.
Yes.
Yeah, I myself Nishu and I am from Delhi. First, we will check the body mass index for the each and every patient for the
Okay.
A, B, and C. Because this is a part of the initial assessment of each and every patient in a hospital. Second, might be we would like to concern the dietary intake for the patient initial, which we will count. So, as per the body mass index and as per the uh, dietary recall, we will just observe, we can just, count the nutritional assessment of patients. So, BMI is most important source to, detect the that nutritional assessment.
Yeah. So you think that the BMI is important, is right? So suppose that,
Yes.
as you mentioned, that we got the BMI. So we calculate the BMI and we got this BMI. What do you think about it?
Sorry, ma'am, you are not audible. Hello.
Yes. So is the BMI is like this. So you can see that Mr. A, the BMI is 24.1. Mr. B, the BMI 29.8. And Mr. C, the BMI 19.1. So it meaning that if we have 3 patients come in the outpatient clinic and we see the BMIs, we are happy with it. So we do not have to do anything with these 3 persons.
We have to do, because this is a one of the part of the assessment. It is not the complete assessment.
Mm-hmm. Yeah. I think for the screening, as we can, based on the screening tool that we heard in before, that they use is either MST or, MUST or other in Thailand. So we can see that the BMI doesn't really tell you much, is right. Then I think that the main thing that, I think that in the term of the screening, they're looking on the, how about the weight change? If we can ask the patient, do they have any weight loss, is right. So it seemed to be the questions that we think about it based on the anthropometry. And based on many things, I think it's just a common and easy, and people may realize and can see on it, is right. Then if we get the information like this, suppose that, in the chart have it, or we can talk with the patients, and we get that the Mr. A, you can see that, this is today is around November 29, is right. In the last 6 months, Mr. A have the body weight 73 kg, and now he has the 78 kg. Therefore, the BMI is increased from the 72.5 to 74.1 in the past 6 months. Whether this is a problem for the Mr. A. So that would be the is on this one. So if we're looking on the malnutrition as undernutrition, Mr. A might not be the problem, is right. Because he is, gain weight on this one. Therefore, but if the gain weight is his concern, so we're looking on the some others treatment or whatever. I agree that for the screening, if the purpose of the screening in the hospital, mainly that for the undernutrition, and to looking, I think in the information that the example of the flow of the screening tool, it seems that we're looking on that, is right. So in this case, it might not be, but except that they come with the specific objective, on this thing, we might go directly on that. Okay. Then how about from the Mr. B? Mr. B, today, he got the BMI 29.8 is right. But, we working on the charge or whether on the information we may got it from him that, today I got 84 kg, but in the beginning of the month, I'm 88 kg. Now I lose weight for 4 kg in approximately a month. Whether it's a problem. And how about Mr. C? Mr. C is, the same thing that today he body weight 4 kg, 54 kg. However, in the last 3 months, his body weight 58 kg. He lose around 4 kg, the same with Mr. B, is right? Is right? Whether it's a problem. So yes, please. Anyone want to say anything, please? Okay, if not, so I think that we're looking on the weight loss, is right. So for the Mr. B, the weight loss is 4.5% within a month. It's a significant weight loss. So we need to identify that is a significant weight loss or not, is right. So it's a significant weight loss. And then is it intention to lose weight or not? For him, we have to think more, is right. Because he come with the, obesity, is right. On this one, BMI more than 75, if people think that it's BMI more than 30. But anyway, he is right that, and he lose weight, around 4 kg in a month. So is intention to weight loss or not? So we need to identify that. If he is intention to weight loss, we may, okay, don't worry about it, is right. How about Mr. C? The same thing. Mr. C is weight loss around 6.9% when we comparing, because his initial body weight is less comparing with the Mr. B. So we calculate the weight loss is almost 7%, but that within 3 months is the same question. Is it significant weight loss? That's right. So I think that
might be it can, because with the Mr. C, there is already BMI is 20.3, and within 3 months he is going for a 19.1. So we can see that already he is having a normal BMI, but he is just losing the weight. So might be it is not losing the obesity, it might be something other. So we have to find out through another thing, because Mr. B is already having a high BMI and high weight, and he lost the weight intentionally. But I think Mr. C is not losing weight intentionally. There is a problem, so we have to find out the diagnosis with another assessment. This is my opinion.
yes, I agree with you, So I think that again that I tried to mention that screening too. So we have many other things that we need to think along, is right. In these ones, then you can see that whether, in your guys that can have the develop of the screening tool that we can, your guys can be used and to be on that one. So I think that the same thing is it intentional to weight loss, and, or is this weight loss significant or not? So that would be the thing that we have to be concerned, on this one. So you can see that the screening tool, they're looking on, 2 things. Mainly is weight, which normally evaluation of the weight loss. I think that we have the common things, Some people may think that this is used for the assessment, which I also agree that we use it more in the assessment. But for the screening and before go further on the assessment, this also is something that we can looking on that, is right. If the weight loss 2% or more than 2% just in a week, and without intentional weight loss. So I think the way that we say it right now is no intention to lose weight. in order to say that if the weight loss is right, they also reflect that people cannot eat is right. So they reflect on that one area. So the appetite or some other thing, whatever, or cannot eat what any reason is right. If it's more than 5% in a month, so that would be for the Mr. B is, in a month is around 4.5%. If the intention we probably ignore is right, because he has a overweight, obese, and he wants to lose weight, so we ignore on that. But again, if BMI is very high like this, but he said that he not, no intention to lose weight at all. However, what happened to him in the past month and make him to not be able to eat, I think that would be concern is right. Although it might not the severe loss because it's almost 5%, but it's not more than 5% yet, is right, but it's significant loss. So I think we have to take care and to find out more, do further on the nutrition assessment. For the 3 months, for this guy, for the Mr. C, yes, we said that it's not yet, is right, because it's just around 6.9%. However, because he is old, also 71 years and non-intentional. So I think also very important is right. So I think that we have to think about it, and consider on the frame size, muscle mass, and, we looking on the enema or not, or any excess of the fluid, when we're looking on the weight loss or weight increase. So we have to looking on this also. So I think that this is just to share you that I think it seems that the body weight is pretty simple. It's just that body weight, and actually you can measure on the body composition in this, some case or some other things, So I think it's defect what? Defect of the adequacy of the energy intake is right. Because to answer or to ask the dietary intake, it takes quite some time. When we put on the screening, it's normally we don't really ask what they eat, but just to say that, ask in details, on that one. But to say that, do they have the same appetite or lower appetite or not be able to eat the same, something like that is right. So this would be something that I think people, just to mention to you that I think I can see more some kind of the waist circumference that might be used, but mostly that it may be more, related with the overweight and obesity. It's just then, as you may know already, that the waist circumference is a common to estimate of the body fat mass and related to the the metabolic syndrome, But if we talk on the undernutrition, so the waist circumference might not be, really, to be used in for the undernutrition much on that one. I think the one that might use is, I think, is around the arm circumference or something like that, especially for the elderly that we want to looking on more detail in the the muscle mass or something that might be used more further and may have more publication related with this one. Okay, then we come up that any challenges for the screening. When is it done? Whether we can do.
Yeah, there are a few challenges.
Pardon?
There are few challenges if they are not able to stand.
Yes.
on their foot. That could be the main challenge.
Yeah, how could you get the body weight properly is right?
By checking their circumferences, their arm circumferences, their leg circumferences. That's how we do even the must too. They are not able to stand up. If someone is amputated, if someone's leg is amputated, especially this happens with the military, post-military challenges. That's how we used to handle the military cases, the post-military ex-retired army cases. That's how we generally assess them.
You mean it for the screening, is right?
Yes, yes. For screening the challenges, if in case they are not able to stand, their legs are amputated. That's
Yeah.
how we used to do. Yeah.
Yeah. So I think that we can see that, you know, for the amputate or what I think, what is the common of the body weight? I think I agree that it's very challenged on this one. Then the body weight might not be able to use and maybe use other, is right, in order to see on this one. Yeah. So, and then if we take in the common, you know, could we do it on the first day of the admission? You think it is a challenge or it's not a challenge at all? So I think in this one, do we every floor, you know, time to complete? I think in this one is right. In Thai, sometimes you can, you know, allow within the first 3 days if they stay longer, is right. So if there's just really short admissions, you know, we not really do it for everyone. So I think that because it take, you know, I mean, people, you know, on people to do it, may be difficult to complete the first contact on that one. If in the OPD, whether in the OPD case to do it for the every case, what kind of the patient that you will do it, is right. How is this done? I think that we already discussed on that one, is right. In the beginning, you know, I think that the keyword that important is valid and reliable, you know. So I think they have some of the question that, you know, whether it's reflect on many of the things, is right. Is it fairly? I think, you know, do they really answer the right thing? You know, is it malnutrition? So in that one, so I think most of the thing that if we, what you call in the, you know, have the study that to do the validity sensitivity, I think in the that I, you know, review you a little bit on that probably can be used, you know, and apply it. But you also can do it in your country or in your own specific area. On own specific disease, you may have to do some kind of the validity and sensitivity, something like that, you know. How often is it done? You know, in case that it's come to be in a normal, do we do it every week? You know, in the inpatient hospital, you know, how could we get the system to do like that? And if do it, I think that whether it's not just to do it, and then what is the results come from, whether they can have the channel, you know, to directly to the nutrition support team or to do the, you know, with the dietitian or something, is right. Suppose that people stay in a hospital for the first day, then nothing happened. However, maybe something wrong in a wrong way. After a week, you know, if the system in the hospital is good enough, or the screening have to be done, you know, on this one. And then what else? Do we have some of the signal to warning that to notify the nutrition support team? You know, so, you know, on this one, I think it's to be depend on the physicians, you know, want to notify or not, is right, if it might come directly on that one. So this is multidisciplinary responsibility. What do you think? That's the story that I told you before, is right. So suppose that they maybe come from some of the surgery, and then, you know, maybe something happened, you know, and then, you know, the nutrition status has been changed, whatever, you know, on that thing, whether the nutrition support team know, or it's depend on whether the physician want to consult or not, is right, the screening on this one, whether they have done the screening in the beginning. So I think in the, you know, and what patients should be done. As I mentioned before, that if we suppose we have 500 beds, 1,000 beds, and you might have maybe only 4 or 5 people in the whole hospital, I think this would be something, is right. It might not be the technique, but I think that the important thing, if we want to find the nutrition at least, and be able to do well further, provide the intervention to reduce length of the stay, to get the, you know, better of the outcome, is right. And as I mentioned, the screening tool for nutritionists that should be validated, on this one. We already talked on this. So in this thing, I just want to tell you some of the validity, agreement, reliability, generalization, and strength of the evidence of the adult malnutrition, which is that for the clinical setting, if we emphasize on the undernutrition on the screening tool. The screening tool that I provide you some example, either MST, MUST, and we not talk in detail on some MNA snack, which is a short questionnaire on that thing, but I can provide you some more reference or later on that one. It's just because I'm not quite sure if we go in all the details and then we, some of the discussion and related with others, we might not have a time. If we have time, we can come back to on this one. MNA, short form with the BMI and NIS 2002, as we mentioned about the first one, the second one, and the last one. So I think they have the study already, as reported by the position of the Academy of Nutrition and Dietetics in this thing, that the sensitivity is moderate, on this one. The specificity for the NIS 2002 is really good, on this one, comparing with the MST or MUST. The positivity predictive value is quite good, not different, on this one. And you can see overall validity, the MUST is pretty good, high, comparing with the MST and NIS on this one. How about the agreement? It's okay. Reliability, okay. Then generalized, is good and fair, on this one. Evidence grade of the strength, how about it's good and strong or it's fair? That, because then if we think that we don't have anything at this moment and we have to do all the, validity, reliability, it may take our time. And what we have to do, I think we can start with some of the things that if you think that is preferred or it might be suitable for your situation, I think that we can use on this one. Then we talk on what is validity. Then, I think that what group of the patients that should do on the screening to do on the screening, I think if we still focus on the malnutrition as undernutrition, what the disease-related malnutrition is, right? So is it all that we should do all the age group to be concerned? It might not, is right? Because in the children, we probably want to looking on the growth, is right? In that one, except that the children have some of the diseases. How about in the adult or elderly? I think in the elderly might have more concern, is right. So I think that, if we have the limited on this thing, people come to in the pediatric. I think the pediatric have the screening, which we don't have chance to talk more, I think in the specific group, they have the strong kid or other things for the disease or for the kid that come to the hospital, is right. How about what kind of the patients that we should do, I think that, can you say that, could we do in the orthopedic? As you may know that, okay, orthopedic, how could we get the body weight? I think they may order, spin or whatever is right. And what kind of the patients that we should, start to have the screening to, if we want it, or the patients, I think, So I just give you the example. I think it's pretty, good in terms that related maybe in our Asian population. So it's a paper on the disease-related adult malnutrition in tertiary healthcare setting in Sri Lanka. So I think it's in our Asian probably more or less the same on this situation is right. The interesting some of the information I got it from this paper, I think it's more recently published, I think in 2007 or, around a few years ago. So you can see it's malnutrition, So they use based on the WHO and using the mid upper arm circumference, So you can see in the patient that they have it, the age around 18 to 49, 50 to 69, and more than 70. The problem of malnutrition is high in the people elderly. It's right. Also the same that if we want to have the screening too, if you have the, the geriatric clinic or whatever, we may have to on this thing is right. Because it's allowed 33.7%, on this one. How about the gender? In the study, they found male more than female. The type of illness that I want to discuss with you. So you can see that, what of the patients that might have the disease-related malnutrition. So you can see in here that for the surgical patients, around 15% of the patients, medical, 20%, oncology, people to have cancer, almost 32% of the patients. Pulmonary, around 68%. Cardiovascular, around 12%. So it's like this. So it meaning that we should pay more attention in the COPD clinic or in the pulmonary clinic and also in the oncology. Is right. If we count that is in the general medicine, including medical oncology, pharmaco, and this thing. So it also pretty confirmed that the internal medicine more problem comparing with the surgery is right. Something like that. So I mean, if we can do it, everyone in the hospital is good, is right. But we may not be able. Then I think that in the conclusion of the study, they said that the study has shown that 1/4 of the adult patients admitted to the tertiary healthcare setting, had the disease-related malnutrition. It's around 25% in overall. 1 out of the 10 were severely malnourished, and around 10% is severely high prevalence was observed in pulmonary disease. And I think in this study, in the table, I not show you that in this one in detail that I think they're trying to using and to answer that, the MUAC, mid upper arm circumference, can be used as a screening tool to identify the disease-related malnutrition in our setting and in order to integrate comprehensive medical nutrition therapy, which, I think there's somebody as looking on the do the study to answer the agreement between the identification of the DIM using the SPEN guideline, and WHO and MUAC. And they can see that the mid upper arm circumference is quite good and get the kappa and the good agreement between malnutrition, and no malnutrition between the MUAC and SPEN, so I think this is just show you on this one. Then in case that we don't have to, may not be able to get a proper weight, whether the MUAC should be used, and I think in what group. I think the MUAC we have to identify and what should be the cut point. I think the data in this area is still not many, but they have the data already on this one. So I just want to expand a little bit on the nutrition list, So in the case that what group of the patients that we should take care and we should do on it is right. So I think we need to understand the type of the malnutrition, which because we have the disease, many of the diseases, and what is disease is related with the inflammation, or not. So I think based on the ASPEN, American Society for Enteral Nutrition, the multi-gen classification as the, nutrition list identify compromised intake or loss of the body mass on this one. So actually they're looking on that whether the patient have the inflammation, yes or no. If it's no, so they classify as a starvation related malnutrition, which is purely that it's because they not eat, not be able to eat, on that one. It's very chronic starvation. They have to get a very low of the BMI or some other thing, or anorexia nervosa, something like that, is classified as a starvation-related malnutrition. For this one, I think that, we can clearly see by looking on the appearance, and maybe go further for the, what you call the more in-depth of the assessment and provide the intervention, However, for the inflammation, it yes, depend on its mild to moderate degree, such as the chronic disease-related malnutrition, organ failure, pancreatic cancer, rheumatic arthritis, sarcopenic obesity, so it's obese but have the sarcopenia. So in this one, or it's another group, yes, have the very inflammation. Inflammation is right. So it classified as an acute disease or injury-related malnutrition, major infection, burns, trauma, or the head surgery or something. So it might be that some kind of this group of the patient, we should take care and define the screening in the beginning, and maybe revisit, monitoring of the screening and provide the intervention is right. I think that I'm pretty, finished on the first part that related with the screening, I'm not quite sure whether are there any questions or any related, discussion with the nutrition screening too, before we go on more in-depth in the nutrition assessment. Okay, so if it's not, could we continue? Okay, then if we complete the nutrition screening is right, we get the people that at least of malnutrition or already malnourished. So the further step based on the nutrition care process, we need to do more further comprehensive assessment in order to get what we should provide the intervention is right. And again, that to be able to provide the appropriate diagnosis and provide the intervention. Then I think that normally we probably know that the component of the nutrition assessment, including A, B, C, and D, which A is anthropometrics. It can be including the body weight is right, BMI, skin fold thickness, muscle mass, percent fat, or something like that, that we include in the anthropometric, including the body composition. For the B is a biochemical data, which including many of it, such as people use serum albumin, hematocrit, hemoglobin, creatine, BUN, something like that, all of the biochemical data. And C is a, physical examination related with the malnutrition, the parts that we call the clinical is right. It can be hair, eye, whatever that we can looking on to be on that. And D is a dietary intake. We try to find how much of the patient really eat is right, in order to get on the thing. And the methodology that used mainly is a 24-hour recall, mostly, or maybe some of the record or do the calorie count, or some kind of this one. Okay. As we mentioned that, assessment from the theory should be A, B, C, and D that we talked before. In the reality, I think you also have to, ask not just, some kind of the history in order to help you provide the better of the intervention, not just, just the day that you go and to see and to ask on that one. So it's a current history, and, food and nutrition related history, I think, on this one. Okay, let's see that. Why do we need a nutrition assessment tool in clinical practice? As you can see in the picture, if we don't really have, the assessment properly, it would be difficult for you to provide the treatment, is right, or want to find something. So it will, if we have the, the tool on this thing, everything easy, then we can, get what we want it properly. I think, I think that is just that. Okay. So nutrition assessment tool, as we may know before, and in the, theory or in the history on this one, is no single or standard way of the assessing nutrition status. So have the various validated assessment to develop. And some is maybe disease specific, some of the age specific, So we will introduce you some of the, the assessment, which I believe that some of you maybe already used it, on that one. We will talk on the subjective global assessment, patient-generated subjective global assessment, and mini nutritional assessment, which I think the last two of this one is more specific, is right, that they develop, especially for the MNA, that for the elderly population. So this will be the subjective global assessment. As you can see in here, I think probably big enough for your guys to see. Otherwise, you can, got the form, HGA from the reference that I provide in here. So they ask is weight change, on this one. So baseline weight, current weight, acute weight loss in the past 6 months, how many % of weight loss? As you can see, the same as we use in the screening, and maybe using the % of the weight loss to include in here. Weight change over past 2 weeks. Are there any weight change past 2 weeks? Also ask a dietary intake. Either no change, it meaning adequate, or no change but inadequate. How could we know this? Adequate or inadequate is right. Then some of the dietary assessment tool that we have to use. And then if the change, is suboptimal intake, protein, how long duration, liquid hypocaloric, liquid starvation, something like that. Then also ask about the GI symptom. Are there any anorexia, nausea, vomiting, and diarrhea? Or never, either how, duration. It can be never diarrhea 2 to 3 times per week, 1 to 2 times per week, or more than 2 weeks or less than 2 weeks for the duration. So this would be the assessment. It's a functional capacity, So are there any, dysfunction or change in function or difficulty with ambulation, difficulty with activity, light activity, or is, bedridden or chair-ridden, or improvement in function, and how long on this one, So I think this is pretty a long time ago that they have the SGA, is right. So you can see SGA is subjective, So the difficulty, I think, is a subjective one. Also ask about the disease state, that comorbidity as related to nutrition needs. As we mentioned, that we probably know some kind of the disease, is a primary diagnosis, any comorbidity, and then is this that disease is increased requirement or not, or decrease the requirement. So I think this would be very difficult for anyone, is right. Have to be used the people that really experience on it, if we're using this form, something like that, whether, acute metabolic stress or not, and for the physical exam, looking on whether they have the loss of the subcutaneous fat, some kind of the physical examination in many parts in the, in our body that can answer on this one, Do they have any muscle wasting in the temple, clavicle, scapula, lip, or something, and with the edema, so, and then providing the score, is right. Then you can see that what they use in the subjective global assessment is a history of the weight and dietary changes, persistence of the GI symptom, functional effect of the disease and the physical appearance as a step that I mentioned in detail a bit before. And you can see that, in the past, in the beginning, the scoring is not clear. Therefore, before on that thing, they try to give you that how would be providing the score, because based on the form in this one is right. It seems that not. Then they also have the details to providing the score on this one. You can see on this one. We used to give the case and let the student in order to use some kind of this and to identify the scoring, but mostly that they have the score really close, but might not be exactly the same, something like that. Suppose that score 6 and another one may say that it's score 7 or something like that, So this you can see on this one. Okay, so the subjective global assessment is just a long time ago that to do it. Although it's subjective, on this one, they also find that the valid assessment too, strong correlation with other subjective and objective measures of nutrition in the literature have the information on this, and highly predictive of nutrition status in a number of different patient groups. So it's pretty good, quick, simple, and reliable. However, need great experience in order to obtain reliable and reproducible results. Based on that, we found that they have to be on this one. That's for the SGA or the subjective global assessment, then have it. Then I will go to next. For this one, I think is to be the predictive, of the subjective, global nutritional assessment on this one. So you can see that they may have a little bit difference in detail on this one, but the items will be follow the same the 5 sections on that one. It's just because for the predictive might have the difference, such as the the appropriate of the current height for age. So if we do for the predictive or for the kid, so we have to go in detail on the, it's a height for age, weight for age, or weight for height, something that to define of the nutrition status, stunting or whatever on that, So then you have that, and then you're looking on the high percentile, whether it's what percentile in order to answer is right. Appropriate of the coexisting of the, orbital high or something, so they have some other detail more on this one related with the growth, that don't have it in the adult or in the first of the subjective global assessment. And then they also looking as a percent of the ideal body weight, is this normally is this within 90%, 90 to 100. 110% is come to be the normal, less than of the 90% of the ideal body weight. Sometimes people also use with the adult, but I think it's difficult or it's challenging to get the very good of the ideal body weight of the adult, Therefore, for me, I think that using the weight loss pretty more easier. And unintentional change in body weight, so that would be. And then the second part will be the adequacy of dietary intake, the same, and also the GI symptom and the functional, and then the metabolic stress or something like that, and looking on the loss of the subcutaneous fat, the muscle wasting and edema. So that would be the for the predictive of the subjective. Then the next one, I just want is more adapted from the subjective global come to the patient generated subjective global assessment, or we call the PG-SGA, which actually they developed in the beginning of the PG-SGA want to use for the specific group in the cancer patient. So you can see that, they have some kind of in here that with the scoring on the weight loss, on the, so many other things, which I think that I can a little bit in detail in the next PowerPoint. As I mentioned, that is for patients with the oncology and other chronic catabolic condition. So including weight, history, food intake, symptoms, and, activity and function. And they also provide you some kind of the scoring in here. So I think this is just to tell you on the, the detail on the, what you call, sorry, this is, I'm not quite sure, but probably not difficult to see, so it's weight loss in 1 month, weight loss in 6 months, and it's a worksheet that's scoring on the weight loss on that one, and, they try to provide you the scoring on, the metabolic demand, on the have the fever, or the catabolic other things, about the muscle strength. So I have to be more specific and have more experience in this one, So there would be some kind of the, the weight, in the first one. I think I should put this before on this one, okay, on this one. So this would be the PGSGA, and another one on the assessment that use it, and I think it more often, especially is developed for the elderly people. So this would be the form of the mini nutrition assessment that they call. Actually, the MNA, they develop both for the screening, which I did not put, talk in the beginning and come and to talk at this time, in order to not have to talk 2 times on that one. So you can see that the screening in the first 6 questions that they identify as A, B, C, D, E, F. So that would be for the screening. And then if this one in depth in the set assessment, in depth, continue from the question G until R on this one. So basically that if want to do as a screening, can just only on the 6 first question. And if the problem as identified that the screening score, which is total is 14 points. So if they have the more score, is good nutrition. If have less score, it's not good, it's malnourished. If it's between 0 until 7, and then further assessment should be done, something like that. And then you can see that, from the screening, probably the same with the others that we mentioned. Ask about the food intake, ask about the weight loss, but for the elderly, they ask something more specific for the elderly, such as how about the mobility or the functional is right. If they are bedridden or have to be in a wheelchair or something, has suffered psychological stress that is more specific in the elderly, have any neuropsychological problems, related with the dementia, something like that. And they're also using the body mass index. That is for the screening. And then for the assessment, they ask more in the same thing that do they, the people that stay in the independently or, in the nursing home or whatever, take more than 3 prescription drugs, which is something related with more in the elderly people, do they have any pressure sore or skin ulcers, do they have the, some kind of the eating that they want to looking on some of the specific, which might be the source of the protein, such as milk, cheese, yogurt, yes or no, 2 or more serving of the legumes, egg, and also meat, fish, or protein every day. So in order to get the idea of the protein intake more, consumption 2 or more serving of the fruit, vegetable, how much of the fruit it, that they have it, how about what kind of the feeding or mode of the feeding, whether they can eat by themselves, or they need help, self-fed with some difficulty or something like that, how about the, nutrition status, is uncertainty, or cell of having nutrition problem, just identified by themselves on this one. in comparison with other people of the same age. How does the patient consider their health status? You know, they use on this one. And we're also using the mid-arm circumference and calf circumference in order to answer the nutrition status. And you can see that screening and assessment too, you know, for the elderly, you know, the condition, and as so many things that I mentioned before is right. Another one, as I mentioned, that if you have a disease that more specific and related with the information and what is the form, you know, to do on the malnutrition information score, which we call in the short MIS. So this would be the MIS, you know, as you can see that for the MIS, they also ask on the related with the, on the medical, started from the dialysis dry weight, you know, so for the people that might on the dialysis, they want to know the dry weight, no decrease in dry weight or weight loss less than 0.5 kg, so they get a 0 mark. If they get more, you know, weight loss, you know, weight loss more than 1 kg but less than 5%, they get a score 2. If more than 5%, they get a score T, something like that for the weight change. They also ask on the dietary intake, you know, have a good appetite or no deterioration of the dietary intake pattern, or maybe some of the suboptimal or moderate overall decrease, something like that. They also ask on the GI symptom, you know, whether they have it mild or more on this one. Functional capacity, any comorbidity, number of years, you know, on dialysis or something. And it would be the physical exam according to the SGA criteria that we talked it before, is right. That decrease on the fat store or loss of the subcutaneous fat, yes or no, and the scoring depend on the how severity, size of the muscle wasting, body mass index, you know, and the laboratory, which using the serum albumin and total ion binding capacity, and they get the total of the score. So this would be the, you know, component classified, as you can see, started from 0 until 3 for the severely, and range from the 0 to 30. The high score also reflect the worst one, you know. How about the Thailand? As I mentioned before, that we have the Society Parenteral Enteral Nutrition, and at this moment, the form that developed, you know, I think inform the physician and others in the team, we come up that have the common of the two forms, which is we call the nutrition tribe NT in separate in the short form, or NAF, which is stand for the nutrition alert form, which both of them are designed specifically to detect malnutrition, which in this case undernutrition in the hospital, and also were validated in the hospital clinical setting. So it has been validated, and then now it's, you know, mostly only these two forms that has been used in many hospitals in Thailand. So I think this it will be something that is a little bit more, you know, but unfortunately some of it's in Thai, you know, but basic concept would be the same, but to get the scoring, but maybe some of the difference, just that one. I'm not quite sure whether in your country have any on the form specific, you know, or use any others. And this is just a little bit that I want to show you, but not go in the detail in that. Also have the, you know, more in the kidney patients, which have to be more what you call to give the counseling appropriately based on the kidney stage, and also what is the treatment of the kidney disease that they have it, either on the dialysis, either in the peritoneal dialysis, hemodialysis, or in the phase that's just a chronic kidney fail, you know. So actually in Thai, and you know, based on the Thai Dietetics Association, also have been helped to develop, you know, some kind of this one to be more specific, you know, and more related in the actually in the dietary one, because would be the really difficult to manage and to on this one. Therefore, we try to do the dietary part more in this part for the kidney and to make as a assessment tool on this one to show you on this. In terms of the, we can say that the assessment, nutrition assessment, you need more of the indicators to be used, is right. Although we have the A, B, C, D as anthropometry, biochemical, clinical or physical examination, and the diet part. But in the reality, based on the anything, are there many of the things that might affect, I think the important on this one, is the food and nutrient intake, which is also the main expertise of the dietitian profession, comparing with the other health professional. So they rely on us in order to get on this information is right. And then you can see that many people, patients may on the many medication where they have any drug nutrient interaction is right. Also the concern that we have to take care, on this one. So the indicator might be growth and what, body composition in some of the certain age group for the growth, and body composition also come up to, in case that we have more elderly population, to, maybe the weight not too much change. However, the loss of the muscle might be more. And if we have to take care in the more specific group, to measure some body composition properly might be very important in the assessment, How about that some other on the social attitude and behavior, how to access the food, this also some kind that we need to think about it and ask and to get the information also. How about the physical activity? Because if we have to determine the requirement, what should be the appropriate requirement of the patients and what group, what is the problem of the patients, and some kind that we may have to emphasize on some kind of the nutrients more or less, on this one. This one also have to be asked, including some other social factor, personal and family medical history, with some we get it maybe from the charge, but some other we also have to find out, and whether that is really when, to the determine the nutrition diagnosis. That also is a part that we have to looking on it. So I'm not quite sure that you'll be too boring that just listen to me or not on this one. So we might have some of the case study and let you guys that to assess, based on that, you might have some experience already, or might you want to use some kind of the form, and we can talk in more details on that one and what form that we want to be used, something like that, So if you have the case, like this. A 71-year-old man has been admitted to the general medicine ward for the first time because of fever. It's around 38.5 degrees. Have dyspnea and tachycardia. Left side bronchopneumonia due to aspiration is diagnosed by on X-ray. 3 months before admission, he suffered from pain in the epigastrium. Reflux esophagitis was diagnosed, based on the endoscopy. The patient received a proton pump inhibitor with only partial clinical effect. However, during the last 3 months, he has lost 8 kg of his body weight. Last week, he was unable to eat solid food and he could only drink fluids. At the admission, his height is 178 centimeter. His body weight 78 kg. Based on the physical exam that related to the nutrition, find out that have muscle wasting at the temporalis and clavicles area, and no skin breakdown. So with this case, whether anyone would like to do the nutrition assessment, please. And any nutrition assessment, what form or any experience in Nepal that have you take care on this part, and have you done any nutrition assessment? Okay, then what form that you think that, we would like to practice together for this case? Then we can, pull out a form that I show you in the, in the slide before, some kind of the PowerPoint, and then we can to see that about this case. What form that we think that we would like to do?
SGA would be better. SGA form of assessment would be better to screen this type of cases.
Do you mean what?
SGA.
SGA, okay. So we want to do the SGA with this case, is right? Okay, then, if you still remember the, this case that, some kind of the information that, the height 178, body weight 78 kg is right. And they lost 8 kg is right. And some of that. Okay, then we go back to the SGA form. This one is right.
Yes.
Yeah. Because we have the scoring in here, then you can see that. So his baseline weight, weight change including on this one. So his current weight is 78, is right. And he lost 8 kg. Therefore, let me try to use the pen, I'm not quite sure. Is right. Current weight 78 kg. So in this case, if he lost 8 kg, then he should have the 86 is right. Then actual weight loss in the past 6 months, how many percent? Are there anyone can calculate for me, please?
It's about 9%.
It's about 9%. Okay, so if this is a case, you can see that, for the 9% loss is right. Actual loss from the baseline, weight change over the past 2 weeks is we don't have the information on this, is right. So if it's 9%, so it will be how many of the scoring in here that we want to put in here, is right. So you can see that the rating of the weight loss is right. So you can see it's 9%. Now it's 9, you got the score from the rate
Rating.
1 to 7. So you got how much? So you
3.
got 3 is right. So you put 3 in here is right. And then dietary intake, they state that they have some decrease is right. So it can change. We can classify is it suboptimal intake is right.
He's actually under the liquid intake
Mm-hmm.
because he was not able to take solid foods due to his epigastral issues, epigastric issues. So he was in a liquid intake almost.
Okay, yeah. And how long it take for the duration? You know, so I think you can see that in here there's like this rating. If we circle in here, you know, we can rating on the 3 is right. And then if the weight loss as 1 point, if the weight loss within 1 month minus 1 point, something like that, you know, we don't have for that in the past 2 weeks. So is this what we want to put in here is between 1 to 7 is right, that we have to rate in here. So in this case, is this borderline, is this poor, or if poor, how much of the poor is less than 1/2 of its share of usual meal, but increasing, less than 1/2 of its share of usual meal, no change or decreasing, or the starvation. So what do you think?
For past 1 week, he was not able to consume solid foods. So he was, since he was unable, he was taking liquid food.
Yes.
So it's not starvation. It is actually, it's not good either. So it should be like.
So you want to put 1 or you want to put 2?
2, we can put 2 because it's decreasing actually.
Yes, you know, so I agree that we may put 2 is right in here on this one. And then the next one is about the gastrointestinal symptoms. Do they mention anything in the case?
He was not having any symptoms except for unable to consume, maybe due to his epigastric issue, because he was already on pantoprazole, that is PPI inhibitors. So that's the reason. So there was no any case mentioned specifically like anorexia, nausea, vomiting, diarrhea. Only he was having issues with his gastrointestinal disorders maybe. So we can't specify, I guess.
Yeah. So if in this case, so if the form you want to put on the 7, no symptoms, or you think that you want to put on the 6, very few intermittent symptoms?
Very, very few intermittent symptoms.
Yeah. Okay, then it would be, sorry, it should be 6, right, in this one. Okay. You know, so that would be something that they put in here. How about the functional capacity? So it's a full capacity, full functional capacity, around the mark could be 6 to 7. Mild to moderate loss, you know, 3 to 5 score, and severe loss of the functional ability as a bedridden, you got 1 to 2. How about this case?
Actually, no dysfunction directly. He was having tachycardia actually. Just recently he was admitted.
So we want to put it as a full functional capacity.
Yeah, full functional capacity related to nutrition. So he was full functional capacity.
Okay, so it will be around, you want to put as a score 6 or 7?
6 or 7. So 6 might be appropriate.
Okay. You know. So how about the disease? Disease state. So in here, what is the disease that mentioned? Let me move this.
the question is not mentioning anything about demand he has. The question only says a 71-year-old man has been admitted to the general medicine ward for the first time because of fever, dyspnea, and tachycardia. So left side bronchopneumonia due to aspiration is diagnosed on X-ray. So he was having bronchopneumonia as well.
So you to think that the disease that they increase the metabolic demand or metabolic stress or not?
Yeah, disease will be actually making nutrition requirement even more. The demand could be there. So actually, because of that only tachycardia could happen. His fever is increasing 38.5 degree centigrade. So naturally, he needs nutrition.
Yeah. So whether the disease is mild to moderate or is very drastic increase.
Increase in metabolic demand, that is between 3 to 5, maybe 4 could be appropriate here.
Okay, so it's in that case we absolutely know that probably increase is right based on the fever and some kind of the disease, and and you think that is for okay is right. Okay, then come to on the the physical exam that we provide you some of the information is right that they may have some kind of the wasting is right. Then you can see is this muscle wasting, they also have the muscle wasting is right. It's no depression in all areas, or it's mild to moderate depression, we give 3 to 5, or the severe depression. So in the
mild to moderate depletion, muscle wastage, it's actually already mentioned. So could be 4.
Okay, so it would be 4.
4.
Yeah. Okay. And how about the fat store?
When muscle wastage happens, naturally fat could increase actually. It doesn't mean that people reduces the weight, doesn't mean the fat will also reduce. Could be a chance when muscle is reducing, the protein and water level reduces, naturally the fat level increases. So that way it could be again 3 to 5, that is could be 3 or 4 again, mild to moderate depletion.
Okay, so but we put again 4. Okay, do this case have edema?
This case hasn't reported with any edematic things.
Should we put 7?
Not 7, but 6 we can put. No edema so far, but inflammation could be there because bronchopneumonia. Inflammation could be there in the bronchitis and lungs area, but not edema directly. So 6 could be ideal.
Okay, so could we sum up on this one? So you can see that the scoring is right in this one. If you sum up this thing, you will get 3 to 5 is right. 6 in here is 11, and another 6, 17, 4, 21, 25, 29, and 35 is right. So on this one, so we can sum up of the score. So in this one, sorry, it might not tell you much on this one, is right. And then we can also do as a nutrition status as an overall of the SGA is malnourished, mildly to moderate malnourished, or severely malnourished. So it depends on very mild, least to malnourished, 6 or 7 most category of significant. So we can, it's very mild. So it is 6 or 7 of the category, or significant. If mild to moderate, 3, 4, or 5 rating, no clear sign of normal. Okay, I think it would be the same that we mentioned in here already. So overall, in this case, what do you think about it in the summary? Overall of the SGA rating. You think that it's mildly to moderate malnourished? Whether you agree with this, or you think that it's severely malnourished?
Can I have the scorecard once, ma'am, for this?
You mean,
Overall SG rating is not visible actually.
I think you can change to the full screen view, and then you will see the overall SGA rating. Because if some view is not full view, then the button will be cut off.
yeah, I try to not use this one anymore, I think. Okay, I think I get stuck in the. The first time I thought I have it in here, but anyway, I may not put it in here. So I may not put in the scoring something there for you to show it in this one. I will add it a little bit later on this one, but maybe we just and do summary on the case. Based on that, you did it, that you can see that, is this case, that we used to do on this one, this must, I think, okay. Maybe I should try to. Okay, I'm putting the score for the total for you later on this one.
Okay.
Just maybe on this one, I mean, just to show you that we used to do this one. Let me make as a full screen. In the different of the screening tool and also the assessment tool, and actually we used to suppose that we have 8 people, and we let them to do the screening tool, and different of the screening tool that you learn that we discussed, and we use the assessment tool. When we use the SGA, the assessment score, then we find out that based on the thing that in the summary they have the moderate malnutrition. And this one just want to show you that in the different of the form that we have it, the BNT-NT is a Thai form, the SGA, the PG-SGA, and some people do the SGA the same, is right. Then you can see that suppose that the people number 2 do on the SGA, and the assessment score, they got 4. SGA is this one, is also 4. I think in this one, then you can see that they get it pretty close and they can identify as a moderate malnutrition. Then when they use NAF, which is a Thai form of the assessment tool, they got the scoring. You can see that it's a different of the score, different of the in the pattern of defining on that. They get 14 and 11. They come to as a severe malnutrition, on this one. And using the MNA, which in generally, I think that this case is not appropriate to use the MNA, but anyway, they also, and if we try the people to do it, the MNA as a short form for the screening and for the assessment form for all the questions. They got the score on this one and get as the malnutrition. Overall, you can see that it will not get exactly the same, but it normally still be in the same category normally on that one. So it's depend on the one that they use it, you know. So it would be the screening score and the assessment score. Sorry that I did not put in the detail on that one. I think that the subjective global assessment, normally they will do on, you know, some kind that, you know, on the 3-4 sides on this one, you know, and then that's why just only on the 5 on this one. And I think that they have a difficulty to give the scoring. Therefore, after that, they try to get the what is the should be the scoring between 1 to 7 and to put on this one. But I should, you know, bring it up that, you know, for the total, you know, how much on this one. You know, I'll give it to you later. I think in another PowerPoint, the set of the PowerPoint. Okay. Then you can see that, you know, if we try with the PGSGA, you know, you also get some of the sense on that. But most of the form that is available in the, you know, in the internet or in the, you know, in the literature that you can try and to see it. Okay. You know, actually we have more case, but we may come later if we still have more time. Okay. Then for the, what is the challenge? I think we discussed a little bit on the screening, what is challenge, whether the challenge of the screening, nutrition screening tool and the assessment tool is the same. What question should be done? What do you think? So we put this in the beginning. You still remember when we comparing between the screening and the assessment is right. And the sum of the challenge. I think the assessment you need require detailed information is right. And you need some time to complete it, you know. And whether the screening come, the nutrition screening, I'm not quite sure. I think that is that for me, if the nutrition screening, you know, they can do it as a routinely and can automatically to send it to the nutrition support team or to the dietitian, then we can looking on that, whether what case that we should go on the assessment is right. Then I think that, you know, in the hospital or whatever, we can set the, you know, the kind of the patients is right. Because you have the, you know, is this oncology ward or it's a surgery ward or something like that, you know, what patient should be done, you know. So I think that it would be, can be set and to be, you know, what, you know, if we have only many, what you call that, a few of the dietitians, if you have how many of the cases that you think that you can do in a day in details is right. And if you still have some kind of the work that, you know, to provide the outpatient counseling in order to get the prevention or promotion, but also you also have to spend time to do the inpatients, you know. I think that if we know what is the, your, you know, what you call specific in what ward, in what group is right, then you can, you know, divide it or manage yourselves. But if you have suppose that have 3 files that you have to looking, whether you can manage well, you know, I think this is something that, you know, what is the criteria on that one, you know, and how is it done? I think that would be the same, that is it valid, reliable scale in the intended population. So I think that when we're looking on the form, you know, if in Thai it's just because we have NT and NAF, you know, so it seems that, you know, either one of them have to be used, something like that, you know, about in your that if you have your own form and that form has been validated and reliable. So I think you can use that form, is right. And if you don't have it, what will you develop, and what appropriate data should be collected, in that case, actually in the simple of the case, whether you have to ask them more on the dietary intake in order to find out how much of the dietary intake of the patient have it at this moment. Because they say they cannot eat the solid, how much do they have it, and what is, I think the main thing that after the assessment, it's not just finished on that, because the difficult one of the, when you assess is, now it come to what should be you provide it, is right. What is the diagnosis on that one? And how would you intervention on that one? What kind of the diet that when you provide, whether the case should be on the enteral nutrition, what would be the case have to be, discussed, and to start in the parenteral nutrition, which, what it should be the, the partial or is a total parenteral nutrition or something. I think that is, often that is consequence after the assessment, is right. And suppose that you already provide the assessment, how often is it done on the assessment? This is might not be relevant if, it's not in the inpatient, is right. If the outpatient, then it may become up that after you provide some kind of the, fully assessment in some case, which I think that is depend on, in the some of the case that you need to go to follow up, intervention and do monitoring in the specific part, may not the whole part, is right, because you take longer time and you might not see the change, really quickly or something like that, I think it is a multidisciplinary responsibility, the same as that, on the one, I think that if we want to the assessment, it might be our part, is right. However, to provide after the intervention, on this one, you also need to work with the people, the physician that, concerned or in the nutrition support team, is right. So I think that what is a nutrition assessment tool? It should be a validated and reliable scale in the intended population, as mentioned, clear definition of the threshold, and compatibility with skills of a generalist assessor. So the thing that, we need to make sure that, people can get the same or have skill in order to evaluate it, on that one. Minimal bias, on this one. Acceptability to the patient, and normally it should have the energy cost, and, and sensitivity to change the score, I think. As I mentioned, that the purpose of nutrition is to collect and interpret relevant patient information in order to identify the nutrition-related problems, is right. I think you also have to think about that to be on that challenge. What kind of the clinical setting that you do it? Is this primary care? Is this an acute illness? It's a chronic illness, is right. Because it will be the different kind of the patients, different kind of the things, different of the goals on this one, is right. Because if we do assess and we not provide any intervention, why we have to do that? And if the intervention have some limitation, what should you do next? I think this is something that we need to think about it. So in this one, I just want to share you something that goes, suppose that it's a primary care, and for the hospitalized patients, although that we talk on the hospitalized patient, which if the hospitalized patient have the policy that to do, we should not be any, much of the problem, is right, because we should have the nutrition support team. But actually, all the hospital is all the hospital have the nutrition support team? I think that would be another question. If you don't have the nutrition support team, I think it might have some limit to do many of the things, to do the, in order to modeling intervention and, how to get the case to refer or, to get you to counseling and to provide the intervention is right. So I think if the setting that we have to take care as a primary care, so normally we identify patients with poor nutrition status, is right. Dietary, detect the dietary habit that increase the risk of the chronic disease. So I think they have some of the different. I mean, the beginning on whether the hospitalized or the primary care in the same that to identify with the poor nutrition status. But the risk factor, so it would be for the primary care, it would be the dietary habits because they're going back home. What is their habit is right. However, for the in the hospital, you may detect the risk factor that to developing malnutrition as a result of the illness. On that one, they have some a little bit different, and then, so you uncover barriers to adequate intake is right. Irregular absorption and metabolism of the nutrients. And you might do, predict risk of the morbidity related to alteration in nutrition status. We're looking on the clinical consequence of the poor nutrition. Recognize patients who will benefit from the specialized nutrition support, as mentioned. We have to provide the nutrition support, special, for the specific case. Assess the impact of the illness on protein and energy requirement. So in this kind of the case, we have to determine or estimate of the energy, protein requirement. Some cases might be in the catabolic state. The protein intake have to be increased. How could we provide it and what route, what kind of the food in case that if they still be able to eat, whether they eat by orally enough, So I think this is also part of your assessment, although it might not be in the ABCD exactly is right, but you also need to endorse this right on this one. Then what route of the nutrition intervention that you can provide, assess is right. Determine illness patient in requirement. If they have some kind that the requirement of the energy might be double, something such as in the burn patient is right. We have more catabolic state, something like that, Detect potential drug nutrient interaction. At this moment, in many hospitals have the clinical pharmacists that we can work with and to looking on the details on that one, Identify need for the discharge planning and patient teaching related to nutrition care. Suppose that the case that from the beginning until the end, they get better and then going home. How to prevent and to get better, we also may have to do on that one. And provides, evaluation a lot during the time. That would be mainly from in the hospital life, which, in the primary care, the intervention is not the thing that you can, what you call order and find it or, provide it to the patients because it's not the admission is right. So it will be more in the outpatient or in the primary care. After we and the dietary habit, evaluate the, medical problems that might be related on the nutrition intake. Maybe we have to assess on the physical activity, track trends of the body weight, or if for the children, for the kid, might be about the growth. Is it properly? Is right? Are there any evidence of the nutrition related of the chronic disease? Something like that, whether they need some of the specific therapeutic diet or not, right? Whether they need some of the specific nutrient supplement or something, on that one. So it would be a little bit on the different and need to think about the preference, in the culture and religious influence on their habit also is right. and mostly that probably provide as a counseling, on this one, and suggestion, some kind that is appropriate for each case, like that one. Okay. I think the thing that, I think that although we discussed on the challenge on many of the things, I think that the dietary intake is something that I'm not quite sure whether you guys think that it's very challenge to get the appropriate, on this one. I think that if in the hospital admission, the intake, it might not too difficult, because if we provide the diet to the patient, so we can get the tray back and we can track how much they eat. However, we also have to make sure that the eating that comes from the patient by himself, herself, not from the relatives, is right. And again, that whether they eat any other things more than the tray of the food that we provide, However, I understand that some of the hospital, although the patient admit, the hospital also not have the meal service. The patients or have to find the relative, of the patient have to find the food for the patients by themselves. So that also would be the difficult. But anyway, it also may not have more, we have to ask, so it's the very thing, it might not much. It depends on how they get the food is right. So that would be to determine what really that the patient eat, how could we get it accurate or good enough, So I think that would be the things that I think is a concern. In the clinical setting and the community or in the population base, it might be have some different. Normally we probably know that, mostly we may get the underestimate of the intake in general, especially in the population or in kind of the patients. If we get the, obese patients, the information we get it might be underestimate more, some kind of that. What tool that we can use and to make sure that we get more accurate, although we use a 24-hour recall or what we use, it is right. And that would be the part of the dietary assessment in order to get of the intake. Is intake meet the requirement? Then I think the part on that, although it's not exactly in the assessment one, but we also have to estimate or predictive of the energy requirement, the protein requirement. Are there any special requirement based on the diseases, We also have to consider many of the factors that might affect this, right? Clinical, nutrition, psychosocial, as I mentioned before, Is it relevant? Is it practical? In order to get an accurate of the dietary, what method that you use? I think that normally, if in the, in the OPD clinic, you don't have the thing that the patient recorded before. If you have to really need and to find the information, I think that it might be the 24-hour recall is right. But we also know that if you recall, whether it depends on the group who do recall. Is it the adult? Good memory is okay, is right. If sometimes that, if we ask from the elderly people, they may not be able to answer you. So I think that would be very challenging. Do we have to then, what is a habitual diet? Might be we ask instead of to use the recall, is right on that one. What is not commonly that they eat it for breakfast? What is commonly eat it for lunch? What is commonly eat it for dinner as a usual diet? And then we might know the item of the food that they eat. The more the difficult part is what is the portion size, is right? And how could we estimate to be the accurate enough for the intake? In some certain cases, we might have to do that. Or in some time that whether we can do just only the pattern, not go in depth in detail on the exactly or estimated of the energy and carbohydrate, protein and fat, something like that, So I think that we also have to be think about it, because everything is take time, and whether we use that data is right, then you can see that if the determinant of the nutrient intake, the common tool that most of the dietitian use is the food exchange, is right, that we can get the picture, what the calorie, protein, carbohydrate, fat. But again, that we mentioned that how could we get a good portion size or the pattern. And again, that at this moment have many of the software program in order to help on this one, whether the software that accurate and can provide you the information on that. And I think the most of the limitation, it can be the food items in the software, and the portion size on this one, So then it's just because the diet pass, people rely on us. I mean, the health professional rely on us, is right. Then we need to looking on the habit balance, potential of deficiency, and reasons for inadequate intake, to make sure on this one. So I think the nutrition history that we talked about before, change in body weight, barrier to nutrition, impact of certain eating pattern, food record, oral hygiene, and actually, especially in some group, such as in the elderly that really, more than 70 years or something. How about the swallowing ability and some kind of the disease such as the post-stroke, So we also have to take care on this one because it might be get on the aspiration or something. I think that this is just to give you just of the summary in case that we can identify, and to assess it, and get the accurate enough. Basically, that's, as we mentioned, that we separate to the malnutrition in the context of acute illness or injury, or maybe malnutrition in the context of the chronic illness, or malnutrition in the context of social and environmental circumstance. What is the criteria? Depend on of the energy intake, Normally you can see that if it's less than 75% of the requirement, for how long. So it's depend on more 7 days, 5 days, more than a month, more than 3 months or something like that. That is classified is to be the concern, And how about the interpretation of the weight loss? So you can see that, if the weight loss in the acute only 2% in 1 week, so it's what if it's a non-severe. If more than 2% is severe, something like that. So there would be some of the criteria. So normally, have the quick weight loss and unintentional is more of the concern. But for the chronic illness, so you can see that it's more that using 5%, more than 5% in 1 week, it comes to be the severe malnutrition. And if we possible to find other equipment that can be used as a physical finding in the body fat, muscle mass, fluid accumulation, and the hand grip, grip strength, which is used more in the elderly population, So we also can use as a criteria on this one if we can do it, is right. Then monitoring of the nutrient intake in hospitalized patient can be relied on the any of the feasible of the monitoring system. I think I just want to pull out on these things just to make sure that now they have many of the software or anything that help, whether is it appropriate and can just we have to evaluate in order to make the the work on the assessment and then provide the intervention and the some kind of the monitoring, so we can looking more as a dietary assessment app for hospitalized patient at Nutritionist, something like that, so I think that will be less time and less burden in something, but we have to make sure that it's okay. I think I almost most of the time at that one. I think we did not talk much on the biochemical. So the biochemical is depend on, as you can see in here, that some kind of the things that we not be able to detect it, because the weight and energy intake probably show clearly on the body weight, outcome of the body composition is right. However, some kind of the certain nutrients such as calcium, iron, retinol, or something, we also need to using the lab value, is right, in order to do on that, and we want to make sure that we can identify, as a vendor, in this one. We don't want to identify when it comes to be more severity, is right, on this one, and come to be have signs and symptoms, So I think if we know some kind of the diseases, that have the potential or have this on some kind of the micronutrient, the follow up by using the lab value, and it might be necessary and to do it. And, actually it would be a little more details on that, but I just want to make sure that we complete all the ABCD. That's why I just even that one. And in almost to summary on this one, the nutrition status of an individual is a result of multiple factors. That's why it's difficult for us, is right, if we go in depth in the assessment, that interact with each other at different levels. The consumption of adequate amount of food in terms of quantity and also quality is one of the key determinants, its impact on nutrition status. And then not just the quantity, is right, the quality of the food is also. And that's why the eating pattern is quite important, especially if you're looking on the outpatient, how we can find the eating pattern, on this one. Some chronic conditions such as coronary heart disease, hypertension, stroke, DM, something like that, adverse outcome that it can be more. So we have to take care and to not be forget on this one. Just finally, that critical thinking skill. I think that to do the completely and comprehensive and get a very good on the nutrition assessment, we need to have some of the critical thinking skill. What appropriate data to collect, the need for additional information, because it might be burden both us and also the patient, is right. Selecting appropriate assessment tool and applying in a valid and reliable ways, we have to, what is relevant, not irrelevant, in order to got that one, in order to get the right information, to get the, the good of the, nutrition diagnosis, in order to be able to provide the nutrition intervention, and not forget to monitoring and evaluation, and maybe to be reassessed is right. If we just do the screening, do the assess, but we not be prepared to add the next step, it also the problem is also not, provide the good of the intervention to the patients. I think I finished, the first part of my, the whole part of my talk, and I will be happy to take some of the questions if the time still limit. This still okay, yes.
Thank you, Dr. Kriengsinyos, for the great talk. You have generated lots of interest because we received many questions for you. So how about we start with a question on nutrition screening. So what kind of methods Thailand use to do early identification of high-risk patients? Which screening test is used in Thailand?
You mean the screening is right?
Yes.
So the screening, we use the one that I showed you in the beginning, that we have 4 questions. Let me pull out that again. So we use this one commonly. Only 4 questions for the screening. Whether have unintentional weight loss within 6 months, whether they decrease intake more than 7 days, but we don't ask that, how much of the decrease, but if we ask that, they eat less more than 7 days, and we also looking on the BMI, as I show you in here, that less than 18.5 or more than 25, and, whether they have any critical disease, critical illness, something like that. If they got 2, yes, that will go on the assessment.
All right. So let's move on to the next question. Which screening and assessment tool is appropriate for a patient in ICU and why?
You mean the screening in the ICU?
Yes, in the intensive care unit.
Yeah, so I think that we have to understand that, normally in the background of the to do in that is in the critical, in the critical period, life threatening. I think there is no screening to do on that one. But after the critical period, on the life threatening, I think that this screening tool not normally not be able to use. I think it will be based on the, normally in Thailand, we're looking on the, what you call that. Now, because many of the hospital have the, what you call the computer, or the information may come up that how many days of the nothing per oral or NPO. If it's NPO more than 3 days, more than 7 days, something like that, is it more than 7 days, that normally, if in the big hospital, they will have someone to take care and to see that what happened with these persons, and if the ICU, whether they get any of the nutrition supplement or intervention based on the, nutrition support, parenteral nutrition or something like that. So I think that, just to be honest, that in the ICU, I think in Thai experience, the dietitian not really go involved much, except that to get consult by on the nutrition support team. If the ICU, the physician in the ICU consult the nutrition support team, then the dietitian will go and looking in the patient within the team, in the nutrition support team. Yeah.
Thank you for the great answer. So the next question is, what sort of body composition technique will be feasible, reliable, and cost-effective in both clinical and community setups?
You mean that to measure the body composition is right?
Yes.
So in that case, normally, I think that based on at this moment, the body composition, that I think that people probably use the BIA, bioelectrical impedance analysis, a lot. It's just because it's easy and it's not really training anything. Just normally, I think it's based on the, the one that you have it. But if the one that just only, what you call, just only on the scale and get the results, which is mostly defect just only in the lower part, not the whole body, they may not get the good results. I think in the clinic in Thailand, if in the related with the overweight and obesity clinic, people use the BIA, but it's the BIA that have the, what you call, have multi-frequency. They both measure both on the upper part and in the lower part. Then they get more accurate on the results of the body composition, both body fat and the muscle mass. However, we have to make sure that the condition of the measurement should be that it just should be, as a protocol, it's just because the BIA, they reflect the body composition by measure the total body water. Then if they just drink the water, or if the bladder full, they may get the, the difference of the results, something like that. And if the patient have the edema or some kind of the, kidney patient, it might not be appropriate to use the body composition of the BIA. So that would be the thing, And then I think that in order to answer on that, now we try to study more and to see that whether some kind of the, what you call, the mid upper arm circumference and calf, basically for the elderly people, might be better or not. And that would be also related with the sarcopenia. If we want to looking more on the muscle mass, also not just really on the fat mass. I think it still be ongoing on that one. I'm not quite sure whether I answer you or not, but it measure the body fat, and related with obesity, people using the BIA.
Yes, I believe the question is answered perfectly. So the next question is about the nutrition in ICU. So do you use Nutri-Score in ICU setting in Thailand?
As I mentioned, that I think that we don't really have much experience on the ICU, on this one. It's just normally it's not the one that nutrition. If we not get, to consult by the patient in the ICU, we may not be able to get in. So Actually, I have no absolute answer for this one. Sorry about this.
Maybe the next question would be the same. How do you identify critical illness or semi-critical illness? Maybe that's the question for the physician.
I'm not clear what.
The question is, how do you identify critical illness or semi-critical illness? So is that something the dietitians do?
I think that they may have some kind of the diseases, I think that they may, have the disease that we know that this disease might really related with the, such as the cancer, cachexia, something like that, so it's a critical on the illness on that one. I think they have the paper that, I think in this one, I can understand that it's difficult to identify whether it have the problem or don't have the problem is right. Then you can see that, they may using, they may have a list of the diseases that these diseases might have to be more related with the information. And this disease, might be related with some of that thing, so we have some kind of the list on that for the dietitian to looking on that, yeah. Such as liver fail, have the trauma, it will be the critical illness.
Thank you, Professor. So the next question is a bit particular. So in case if we cannot measure hand grip, can we skip it in case of SGA? Like, can we skip the hand grip and use SGA instead?
I think it's added on this one. So if you don't have, it's okay that, the SGA would be the common because the subjective global assessment that you can use this. Yes, But I think that hand grip, it can be more some kind of the diseases, such as in the elderly group, and also in the COPD patients, something like that, that they want to reflect something that, if they can increase the muscle mass or they increase the strong of this one, and also it also reflects some kind of the breathing, something like that. Yeah, if you don't have it, it's okay.
Somebody has turned on their microphone, and please tap to mute your microphone. Thank you. So the next question is, we have limited dietitian in Nepal. What is the best way to do nutrition screening in more patients with minimum manpower?
Yeah, so I think this would be the issue in many places, including in Thailand. In some kind of the nutrition screening, actually the nurse is a person to do it, or some kind in the OPD. Actually, it's some kind of, I'm not quite sure it's as a nursing aides, or it's not the nurse, it will be the, the people that to help, and actually, as I mentioned, that if you get the very clear in some kind of the thing that one, and this is, how much, I mean, in my experience that I used to do in, to try to set the dietary counseling in the COPD clinic, then they come up that the people that, measure the body weight and some kind of the thing, they have a form, it's a nursing aid that they will check some of that. So if the score is more than, suppose that in that form is more than 3, they have to refer to the dietitian. Then they will put on this thing and they make something that, in the front of the chart, in the color, something like that, we have to see the dietitian, something like that. So that would be the project that I started, because in that hospital would like to make as an excellent center for the COPD or something like that. Therefore, they try to set that should have the dietitian in order to provide the counseling, in some kind of in that population, we can do that. Then, in my sense, I think that for the hospital that, maybe big enough, or now they have the, what you call the IT, it's a technology, is right. I'm not quite sure whether you can add it up in some kind of the things, the question for the screening in the term for the admission. If the admission, you need to ask this, or something like that, in this one. If you have to ask on, suppose that have 3 or 4 questions on that during the admission, and the people that get people to admit can ask all the questions, is right. And that question also fill in the computer system. And that computer system have to be what you call the function that go to what anything. And then you can looking on that one, and then you can say, oh, okay, this is pretty severe, something like that. And then whether we can go and to see the patients. And this might be, I think that in this case, it might have, it's depend on, because if the question is more related with the adult patients, so it have to be only in the what floor that they have to do this, and we can go on this one, and that it will be reduce your time and reduce that you don't have to go on the screening, is right. But you have the warning that come from the information system based on the common people. But the problem that we found out when we do that in some hospital is the, you got to fall positive, something like that. Actually, it's nothing at all, but it maybe have something, just error on that thing. Actually, this person don't have the problem on nutrition at all, but it come up is nutrition. Therefore, the system have to be good enough in order to do like this. But it will help a lot, and it reduce the problem on this one. Yeah.
Thank you for this very elaborate answer. So the next question is, in stroke patient who is bedridden, who cannot stand who cannot stand the nutrition assessment tool, then what kind of nutrition assessment would you suggest for a stroke patient who is bedridden?
You mean for the stroke patient which cannot, stand, is right? The thing that you will not get the body weight, is right? I think the important thing that, this would be very challenging, but the best way that, if in the hospital, they should get the, the scale that you can, weigh the patient on the best scale, so on that one, then you can get, and should be the minimum of the cloth is the same thing, and they can, weigh or, lift the patients and you get the body weight. I think that would be the best way. However, for the stroke patient, that if they cannot, they cannot stand, but they be able to sit, I think that to have the wheelchair scale, that also the best way, to do that, which we also have the wheelchair scale on this one. And it's not difficult if we can make them, to stand, to sit on this one, and then you can see the change, on this one. And for the wheelchair scale in the OPD, that we did it, that all the wheelchair have this weight of the wheelchair. Then they have the scale that you can put the wheelchair with the patients, is right. Then after that, the people that record the weight, they just, looking on the scale weight with the wheelchair, and then minus the wheelchair weight, and they get the exactly of the body weight of the stroke. Why I say that we might need to put this effort, it's just because that if the stroke patient is a chronic case and it's a long term, and if they may not be able to eat by themselves and you provide the tube feeding, it might be possible that to overfeeding, and also it might possible to underfeeding. If the overfeeding, then you gain weight too much, it's difficult for the, the caregiver to take care. But if to provide the undernutrition, the recovery phase will be slow and may have the problem on this one. I think in order to do that, I think have to be put effort in order to do on this one. But in terms of that would be for the body weight, which it should be good enough on that one. And we might using some of the anthropometric upper arm circumference in order to calculate and measure some of the skin fold in the bicep and the tricep in order to get the muscle. I think that would be the good of the effect. And another part that people try to do it right now using the calf circumference, in order to answer the more in-depth in the body composition. But that one also not get the body weight. I think it's very important try to get the body weight. I know that it's quite difficult on this one. Yeah.
Thank you. The next question is, where can I get more data on spent nutrition too?
More data.
More data on SPENT, the one that you use in Thailand, the nutrition screening tool. Where can they get more data on that?
You want NAF and NT is right?
They say spent, like SPENT. I suppose.
That is society. That is spent is a Society Parenteral Enteral Nutrition in Thailand. It's spent, and we have the form that's an NT form and the NAF form. I think if you're looking on our website, I think it's managed to be in the Thai language. It might be difficult, but if you need the NT form, and NAF form, I think I can give it to you. I mean, and then you can, provide it to other people that really need it. I think I have the form in English. I can give it. Yeah. And actually, I may log in the afternoon, and I can put in the chat box. Otherwise I can give it to Mo, and I think you can maybe give it to others. Yeah.
Thank you, Professor. That would be very helpful. So we have one last question before we wrap up for lunch break. So if the hospital has limited resources to do nutrition screening and assessment and has to focus on a few groups of patients only, then which patient groups should be prioritized for nutrition screening and assessment?
So I think it's depend on the policy also, no. So as I show you in the study in Sri Lanka, in the beginning I thought that the cancer patient is right, but the cancer patient also is depend on that how aggressive of the treatment and the recovery. But I believe that certain kind of the cancer actually they get a really of the can be stay long, a long time without a problem, So I think in that kind of the case that we should be taking care and looking on it in terms of the malnutrition is right. And also you can see that in the COPD patient or something, I think the good life, after they get, stronger in a thing and provide a good nutrition support on that one, they also get better, So I think that I'm not quite sure what is the health problem in their brand and what is a chronic disease that come up to be on this one, and again that I think that the patient that have more problem related with the GI tract, it would be the the group of the patients that have the problem that related with the nutrition and really need the taking care, and if we provide the taking care very good, either the short bowel syndrome or others anything, they will have a very good life and get a very good outcome of the after the treatment. Yeah, I'm not quite sure whether I help you or not, but it would be also the same with us, in terms of many of the hospitals that have the limited. I think then the thing that it depends on the policy, as I mentioned, that they want to emphasize on the chronic diseases, and also looking on the OPD or not, and if we want to do the more prevention and promotion, then the screening, it might be come back in the more in the overweight and obese, if the overweight and obese still be the, related with a non-communicable disease and it's more in your country. But I think this one is quite difficult in the case that because it's a habit, and it also because depend on the available of the food that people easily to access it, So I think it will be a difficult condition that to do that. But if you think on just only in the hospital like that, in the admission, I think that in the internal medicine, with some kind of the GI disease, which might be the appropriate one because they will have more problem on the diseases, and most of them might get a very good outcome if they get a very good intervention and related with the nutrition.
Thank you very much, Dr. Kriengsinyos. It has been a very great and informative webinar this morning. So now our time is up for the first half of today's webinar. We will have a short 20-minute break. See you all again at 11:50 p.m. Nepal time. So enjoy your break and see you soon.
Okay, thank you. Bye-bye.
Thank you very much, ma'am.